actionable data, there is problem in modeling the systems. You cannot generate real-time reports. And here's where data analytics AI that come into place. So Einstein Copilot for Tableau, they can data gaps, generating synthetic databases where real data is inadequate. So that this Einstein Copilot really helps to anticipate the outcomes with predictive analysis, which will simulate diverse scenarios and uncover hidden correlations. It is also going to help different sort of people to do analysis who are in this field of health research, whether they have limited statistical understanding. Uh, they don't need a high degree in statistics. There is also a lot of data, AI, data in AI or AI in data integration happening. There's a lot of harmonization is there that how health information is getting consolidated. There can be different sort of NLP based matching algorithms which will actually recognize and link the patient records across different systems. Real-time dashboards, we all know that there are different sort of real-time dashboards, and I think we have seen the National Health Mission, how they are deploying different sort of machine learnings, which are continuously analyze the different sort of data from multiple sources. They have the HMS, the Health Management Information System data, the reproductive child level data, and district level inputs. So this natural language processing for unstructured data has another wide angle. They are also working in different states of India where thousands of ASHA workers data, in fact, they are thinking that this is not completely launched, and they are thinking of this ASHA workers data to get clubbed. So that what is going to happen is community health challenges will not be faced. And one of the leader on this sort of data set AI and exactly this sort of data is Vadbani AI, which this non-profit organization which has developed several open sources. They have done. They are working on a voice recognition tool. So you have just have to ideally, if a new health provider joins as an ASHA or an ANM, they would be able to understand different sort of experienced ASHA worker cases. So the dialogues between a pregnant or elected, that transcript would be available in that local language. So quite a lot of work is happening. Still a lot more to go, definitely. But yes, we are very hopeful that with the successful AI coming in, we will see this. We will overcome this challenge. That at least we are definitely hopeful on this.
Yeah, I think that's fair. That it's actually not adding to the burden of the work, but it's simplifying the work. Where it's the speech that can be easily converted to text, and that can be done in multiple dialects. Just coming to what I think Naveen alluded to earlier, it's the Family Doctor Day. And I think one of the strengths of family doctors has been the fact that they are aware of the burden of disease among the communities they serve. Now, what is lately happening that there is a rising burden of disease of non-communicable diseases. It comes without saying that we are seeing this emergence of non-communicable diseases in large proportions. There is a lot of there is a large chunk of population. In fact, you just see the news. You see a lot of celebrities, a lot of entrepreneurs who are seemingly of good health, succumbing to a sudden, episode, a sudden stroke or something of that sort. And many of them you get to know are diabetic. So with the silent killer, which has led to multi-morbidity, premature mortality, how can actually AI help in the prediction of the population at risk?
I have lost you, Anuradha. Anuradha, I'm not able to hear you.
Yeah. I was just asking about the increasing burden of the non-communicable diseases. The fact that, family doctors used to act as a conduit to understand what's the burden of disease among the community. Uh, So how can AI help to predict the population at risk and identify the belts or the zones of population and catch them sort of early to mitigate mortality?
Okay. Yeah. This is really very crucial because uh, understanding the true burden of disease is very for health system planning and challenging, but AI is offering very promising approaches. AI NFHS from the sample SRS data, sample registration system data, different sort of hospital records, the community service, which will obviously include diseases like TB, different sort of eye care, and they will give very good predictions and very good estimates that what's going to come up in the future, and the service delivery mechanism can plan accordingly in which part exactly this prediction is possible to do. And there are also NLP tools for analyzing clinical notes, which will really uncover the hidden patterns. I'll give you an example. This is not tested, but I was reading in one article that researcher would be able to really apply NLP over a sample of different sort of psychiatric consultations to they will be able to recognize the patterns of comorbidity, and comorbidity is an issue here. So for example, different sort of mental health conditions and physical ailments. So maybe there is a thyroid disorder, and the data will show you that this was significantly underdiagnosed among patients with depression, the thyroid disorder. So this sort of trends will come in when these sorts of clinical notes are analyzed. There is also one computer vision analysis of medical imaging which is happening. So, for example, the AI-powered chest X-ray, which is extremely important for these TB centers in India, they will not only detect tuberculosis, but it will also identify the patterns of COPD. They will identify patterns of or symptoms of early heart failure, lung cancers. Also, in this area, Niti Aayog is working a lot on this diabetes aspect, which you had just now mentioned. They are developing an AI algorithm for detection of earlier signs of diabetic retinopathy in diabetic patients, and to scientifically validate the algorithm, which can be used as screening tool in the primary healthcare. That's what is in my mind at this moment.
I think for me, there are three key takeaways from all these points, very relevant examples which you have put out. One is the fact that how governance overall, the governance of a health system can benefit through the utilization of data, through better monitoring, through better evaluation, and in turn, better supervision. That's one element. The second element, which really stands out, is the whole ambit of service delivery, be it the primary healthcare. You gave a lot of examples on how primary healthcare can benefit, how hospital healthcare can benefit, how the supply chains, the cross cutting supply chains can benefit, and how finally, to top it all, how the health financing could benefit. You talked about the actuarial data, you could use synthetic data sets to generate a lot of information. But to top it all, to kind of connect it all, there is the health information exchange, which is definitely needed for a strong primary health system and in turn for a family doctor led system. So I think for me, these are the key takeaways. If you have any closing remarks, otherwise, we'll hand it over to Naveen for Any audience questions or any other discussion points?
Yeah, I what I feel is obviously India will need significantly more healthcare professionals. So here again, AI will come into place because as you know that currently the doctor-patient ratio is about 1:1,500, and the WHO recommendation is 1 to 1,000. Even the nurse population is low. So in actual service delivery, when AI will feature in and they will provide some certain sort of powered clinical decision support system, this problem will solve. And in country like India, telemedicine is coming in slowly and slowly. This mobile diagnostic devices are coming in, which will extend specialized capabilities to the remote areas. There will be smartphone based eye examinations. We have to use it more carefully. Good dissemination needs to be done. Which will come to the health providers, which will really facilitate and make lives much better. And that's what we can hope and we expect. Yeah, that's all from my side.
Thank you so much. We hand it over to you, Navneet.
Thank you, Dr. Anuradha, and thank you so much, Tathagatji, for your rich and insightful discussion. What I will do that I will put forward two questions to each of you, and we can emphasize based on that on the question. So, first question to you, Tathagatji, that have there been, because you spoke about COVID and Khushi Baby, different things and all, but there is a specific question that is there any successful example of using AI in primary healthcare and basically in underserved areas? And what can we learn from them? And what can you take away from this existing platform?
Yeah, definitely. I can give you certain examples, which is exactly used at the grassroots healthcare. For example, there are diagnostic tools like different sort of images scanning, different sort of text result scanning. There are different sort of AI chatbots, which is really helpful for the health workers with up-to-date knowledge, and this is available in different sort of languages. There is a lot of thing happening. This has started, but this is gearing up widely. Is the data collection and management. So health data. I'm not talking about the survey data exactly, but health data. Health data is getting collected through AI. There are different sort of disease strains which are analyzing. I mean, coming in understanding much better. Remote consultation is again one area which has started in penetrating in rural India. Supply chain I have already spoken about. And what I feel is that the lessons learned is the main thing is all these things should be adapted to the local context. So otherwise things will not get successful. So all the AI tools which are getting developed or which can develop, they should be tailored to the local language. They should address the relevant diseases in the local context, the cultural practices, and there should be integration with the existing system. So rather than completely replacing them and getting into a new system, they can tie up with the existing systems because India has already spent so much of money in healthcare since independence. So they should always add up to the existing healthcare system. So these are the two things, lessons learned, which is coming to my mind.
Thank you so much. I think there is one next question, so which is coming from our experience of AI, especially because when there is a digital platform technology, there are a few challenges to it, and when we will take downscale to it towards the more grassroots level. So the question is that how AI can be handy for these grassroots health workers, and what are the things that needs to be considered?
Yeah. So obviously, which needs to be considered are these sorts of technologies should be made available in the first place. There should be good connectivity everywhere. Still, there are remote areas where connectivity becomes an issue. And obviously, training is one good area. AI, because I'm coming from the point I have taken several trainings on AI. There is still some sort of fear which exists in AI, which is not completely unjustified. There has been mishandling AI issues also. So this sort of training will completely remove the fear where whether AI will not go right. These sort of things may be met. But ideally, this sort of chatbots, I mean, which are the end user application. These sorts of application works very well with users. They need not be bothered about that. What is exactly behind getting into this AI tool? So, and in my previous answer, I also mentioned that what will really work is adapting to local conditions where there is some sort of rigidness. Things should be handled in a more different manner. Obviously, connectivity is one issue across different areas, particularly in remote areas like Andaman and Nicobar Islands, Lakshadweep. Their connectivity is very big issue. Even you don't get mobile connections. Also, I mean, you may not think about internet connectivity regularly. So these things should be sorted, and different sort of mobile health applications should be promoted much more in different sort of personalized treatment plans.
I think thank you so much. These are very in terms of the specific things that when in terms of innovation and making it enable for the adoption of the AI technology can be considered. And digital infrastructure is one part, definitely considering the geography and penetration of it. So taking forward this, I think I have two questions for Anuradha as well. So Dr. Anuradha, just we want to know that what are the some ethical concern or risk which is involved in deploying AI. So, because coming with the perspective of health indicators and various insights which can be accessed or hosted towards different platform. So, what are the basically these concerns, especially regarding the data privacy and consent?
Yeah, sure. I think I'll just build on what Tathagat mentioned around the National Digital Health Blueprint. So along with the National Digital Health Blueprint, we had a health data management policy which was launched. Now, the health management data policy actually talks about the architecture of Ayushman Bharat Digital Mission. It was known as National Digital Health Mission, NDHM at that time. So with all the artifacts that National Digital Health Mission or ABDM now, as it's known, has, there is an artifact of informed consent, which is very obviously very important. It's a part of the whole architecture. Now, that having said, there needs to be a deeper understanding when the people are collecting the data of what is one, data privacy, which is through informed consent, and the second is what is data safety. Now, data safety is something which is essentially over and above. It's the policy when it comes to data. Now, ABDM governs the data through something known as federated architecture, which means essentially that the data which is present at the level of the facility, the decrypted data which is at the level of the facility, whenever it is given to the higher ups, it has to be encrypted, which means even the district officials will not have access to the patient data. So that's the second level of just trying to understand that there are a lot of misconceptions also when it comes to ABDM, but ABDM has taken care of all these things in its whole discussion, its policy ambit. I think the last thing which I want to speak about is that unlike a lot of other countries, India has an opt-in policy, not an opt-out policy, which means that I can choose to become a part of a system or I can choose to not become a part of the system. Unlike a lot of other countries where you have to become a part of the system, then later on you can opt out. So in India, that's still voluntary, largely voluntary. Same for the public health organ, same for the private and the public health organizations also. So I think that's these are some of the things which govern the I think privacy in terms of data. obviously AI is a very different ball game altogether. I'm not going there, but at the level of the data collection, these are some of the safeguards which are at place. And AI is probably a whole different lot of discussion, which probably we can have a part two of this webinar. We propose that.
Definitely, sure. I think uh,
Definitely.
we'll go ahead this. And one last question to you, Dr. Anuradha, that because we are talking about data, AI, and use of this data. So there is one strong pillar or the connecting factor, which is the community health workers, and they play an important role in terms of overall the ecosystem of data and related to health. So what is the, how they play in bridging this gap between this AI based tool and the rural patient, because they are the basically play mid role in terms of connecting this data to a platform. So what is how they are, what are the role that they are playing, that is bridging the gap between AI based tool and rural patients?
So I just was counting the number of times Sathagat said contextualization. I think that's a very important word in the whole discussion of AI and ML when it comes to the Indian health policy ambit. So contextualization or understanding the colloquial terms and translating that to a clinical decision support system is only possible if we are constantly in touch with the frontline workers and the community health workers who understand the community language better, and also the picking up of the dialects, like uh, I mean, when I've worked a lot in South India, so at times I don't really understand the terms which are medical terms which are used in North. So there are some very typical terms which are used, and that will add to when the patient actually gives his history, the chief complaint, that it has to be recorded in the same language. So I think that understanding the community health workers bring in. The other thing is they are the ones who are going to adopt it and adapt, and eventually we would adapt it according to their needs. So I think the needs assessment should start with the community health workers. But when you're trying to understand what has to be the need of the community health worker, it starts at that level. And then it goes bottom up and not top down. So I think, and data is also collected bottom up in India. So maybe that's something which I feel is their role to play, and that can in turn be connected to the rural population.
Yeah, I think that is the consistent process which will happen, and maybe a lot of other players in this ecosystem who have a strong responsibility of connecting this data to a larger platform, and especially the community health workers. So we'll continue this conversation in terms of like who are these other stakeholders, how they can use best of it, and they can also be part of it. So we'll continue this discussion, and thank you so much, Dr. Anuradha and Tathagatji, for this thought-provoking insights. And what we have heard today, which reinforces the immense promise of AI, which holds like transforming rural healthcare, but also remind us the real challenges around equity, access, and responsible adoption. So at Vayam, we believe the future of healthcare must be collaborative, community driven, and tech enabled. So in today's conversation, we bring one step closer to that vision. And we are grateful to each of you who has joined this webinar, from public health professionals, NGO representatives, and community health workers, including researchers. So a big thank you to our speakers again, and for generously sharing their times and expertise. We wish that we'll continue this session again in a more informative and more collaborative manner. So thank you once again. I wish you all a great day ahead, and thank you once again, and goodbye.
Thank you.
Bye bye.
Most welcome. Take care.